We're going to talk about what's new in ED respiratory support. I am a little biased, but I think that this is an incredible topic. I think this is really the kind of topic that separates the wheat from the chaff when we're talking about taking care of the critically ill in the emergency department. And I want to throw something out there right now. I know I look like I'm 12 years old. I promise I'm getting older. I'm starting to feel it. I can only have one drink before I go to bed at night. But we're going to jump in. And the first question that comes up is, what is the role of high-flow nasal cannula in respiratory failure? This is an incredibly complex topic, and there's so many nuanced facets. And when we talk about the role of high-flow nasal cannula in respiratory failure and respiratory support, it behooves us, and it's important to start with framing the question and where does this come from? What is high-flow nasal cannula? And really that's what that first abstract talks about, is what is high-flow nasal cannula? This you may have encountered in your emergency department. This is OptiFlow, this is Vapotherm. Where does this come from? Believe it or not, unlike everything else in medicine, this actually comes from pediatrics and into adult medicine, where they have these little babies in the NICU and they were getting the oxygen shoved in their nose. These little babies were uncomfortable, so they created a different type of nasal cannula. It's a little bit of a wider bore that goes into the nostril. It can deliver higher flow rates of oxygen, and it led to better outcomes for these babies in the NICU, and therefore was then extrapolated out into the adult world. And what is this? It's high-flow nasal cannula. It's a larger nasal cannula that can deliver higher rates of a fraction of inspired oxygen, whereas we know the lore that every 1 liter of oxygen you push through a nasal cannula in the ED, you're increasing your FiO2 by 3 to 4%, depending on whether the patient's mouth is open or not, right? So when you put a patient on Vapotherm or OptiFlow, on high-flow nasal cannula, we're talking about fractions of inspired oxygen of 100%. We're talking about flow rates of 30, 40, 50, 60 liters per minute of warmed, humidified oxygen that patients can tolerate quite well. And what this first article tells us is that it appears to be extremely well tolerated in patients, that they seem to do quite well with it. Patients don't hate it. It seems to be fairly easy. So then we move to Article 2 and Abstract 2, which really I think is one of the defining articles of our generation. There's a lot of stuff that comes out of this Abstract number 2 known in the world. So this is the Florali trial. So what did the Florali trial do? Understanding the Florali trial and understanding all the differences and nuances of the Florali trial will help us understand all the nuances and differences of respiratory support in the emergency department. So we're going to spend a little bit of time on the Florali trial. What did they do? In the Florali trial, they took patients with impending respiratory failure, with respiratory distress, and they randomized them to one of 3 groups. You could get standard oxygen, and this was a non-rebreather mask, right? You threw a patient on a non-rebreather mask. Generally, they said at a minimum of 10 liters per minute. So right there, we can pump the brakes a little bit. I hope not many people are maintaining patients on non-rebreathers at 10 liters per minute and sending them off to the floor. It's a little bit of a respiratory for a rapid response in about 10 minutes. But that was the first group. The second group was non-invasive ventilation. They put them on CPAP or BiPAP, right? We're all very familiar with that. And the third group was this Vapotherm, this OptiFlow, this high-flow nasal cannula. What they sought was this. They said, all right, we randomized these patients to one of 3 groups, and our primary outcome is endotracheal intubation at 28 days, all right? Am I able to avoid intubation? And we know from previous experience, everybody here knows that things like non-invasive ventilation can decrease the need for intubation, and it's known as the great stealer of endotracheal tubes from emergency medicine residents, right? So we know that some of these interventions can decrease the rates for intubation. So they wanted to see, is OptiFlow's high-flow nasal cannula better than one of these other interventions? And I want to spoil this for right now. There was no difference in the primary outcome. But the primary outcome here is the smallest contribution to what we can take away from the Florali trial. Let's look at the secondary outcomes. And I know that secondary outcomes can only be hypothesis generating. The EBM purists, I think Ken Millen is waiting in the wings somewhere to tackle me for talking about secondary outcomes. But when we talk about secondary outcomes, they're informative, they're illustrious, and they're important. So what did the secondary outcomes find? Is that patients who were started on a high-flow nasal cannula versus patients that were started on non-invasive ventilation versus patients that were just continued on standard oxygen, they died less, all right? Whoa, right? So they died less. And there's so many important things to take away from there. And the first thing to take away there is that At a minimum, high-flow nasal cannula doesn't change rates of intubation when compared with other things that we can use, and maybe less people die. And listen, I'm in that business, all right? So I like that, and that's important. What else did it teach us? It tells us that maybe we've forgotten what we're supposed to be doing with non-invasive ventilation. Many of you may have worked before we had non-invasive ventilation. Before I was a physician, I was in EMS, and we didn't have the ability to do CPAP in ambulances like we can now do. We didn't have that ability. And you have to think about, why did we develop non-invasive ventilation, and how have we, let's be honest, bastardized the use of non-invasive ventilation in the emergency department? Because we use it a lot and we use it poorly. Non-invasive ventilation is not CPAP, BiPAP is the same thing, all right? First thing we need to understand is that there is a difference between CPAP and BiPAP. And when we put the patient with CHF who comes in and we just mindlessly throw them on BiPAP, we're doing them a disservice and we're practicing bad medicine. Non-invasive ventilation is a tool. It's a tool that's used to bridge patients. It can only ever be used as a tool to bridge patients. It cannot be used and say, oh, listen, you're coming in with pneumonia, let me throw you on BiPAP. That doesn't make any sense because it can only be used temporarily to correct an underlying problem. Let's look at the use of non-invasive ventilation. Let's look at the use of BiPAP. Why do we use BiPAP in COPD? It's been associated with an 18% decrease in mortality when used in patients with COPD. We don't see good studies in patients with asthma because it's been deemed to be nearly unethical to use that in patients with asthma because it's so clearly beneficial. BiPAP is beneficial in patients with COPD in a number of ways. It does increase oxygenation if it's necessary, which isn't often strictly necessary in patients with COPD. But that difference between the IPAP and the EPAP, the inhaled positive airway pressure and the exhaled positive airway pressure, is what drives ventilation. It's what goes ahead and decreases CO2, which is often the underlying sort of pathologic cause in patients who are presenting with respiratory failure in COPD. But then if we try and take that lesson and apply it to a patient with CHF, we can see that we're already beginning to bastardize our non-invasive ventilation intervention. Why do we use non-invasive ventilation in a patient with CHF? We don't use it to drive ventilation. If a patient in CHF is presenting with a CO2 of 90, they got other problems. It's not their CHF that's driving their CO2 of 90. The reason we use non-invasive ventilation in a patient with CHF is for modulation of those Frank-Starling forces. Think back to your days of medical school and PA school. Think back to those ridiculous lectures that we sat through and said, what the hell is this? But that's what we're doing. We're decreasing preload, we're decreasing afterload. And the addition of an IPAP, EPAP, a driver of ventilation, makes no sense in a patient who presents with CHF because they simply don't need it. And what has every single study seen that has investigated this, have seen a non-significant every single time worse outcomes in patients who are receiving BiPAP over CPAP. And every single study doesn't find profound differences, and every single study doesn't find more people dying left and right when you put it on. But when you have study after study after study that shows that patients do worse with BiPAP than they do CPAP and CHF, it tells us a few things. That it's time to stop talking about non-significance, and it's time to start talking about patterns. And it's time to start thinking that we need to be a little less mindless in our application of respiratory support in the emergency department. And that brings us to this lesson of patients who presented in Flurali. Who were these patients in Flurali? They had hypoxemic respiratory failure. These were not COPD patients. These were patients largely with pneumonia, pure hypoxemic respiratory failure. And so we can see right off the bat, why would there be a suspicion that non-invasive ventilation would be beneficial in those patients? Because why do we use non-invasive ventilation? We use it to drive ventilation, or we use it to modulate Frank-Starling forces, or we can use it to increase oxygenation in a small cohort. But it doesn't do those things principally. It drives the Frank-Starling forces and it drives ventilation. So non-invasive ventilation never should have been considered a routine go-to in patients with pure hypoxemic respiratory failure. And perhaps the reason we saw the differences we saw in Flurali were not because of the excellence of high-flow nasal cannula and weren't because of the excellence of standard oxygen therapy, but perhaps were because of a misapplication of non-invasive ventilation all along. Maybe hypoxemic respiratory failure, maybe high-flow nasal cannula isn't an astounding and amazing thing. Maybe it's just better than the bad things we were doing previously. And that, as we move through our abstracts, is a theme that becomes quite clear. When we move to our third abstract, we look at a meta-analysis of high-flow nasal cannula compared to non-invasive ventilation. And what did it find for us? It found that there was no change in mortality in patients who were receiving high-flow nasal cannula versus other interventions. But when you looked at high-flow nasal cannula, you saw that less patients got intubated when compared to standard oxygenation. About the same amount of patients got intubated when compared to non-invasive ventilation. So that's the same lesson we're getting from Florali, that at a minimum, high-flow nasal cannula is just as good for oxygenation when compared to non-invasive ventilation. At a minimum, it's just as good as non-invasive ventilation when compared to rates of endotracheal intubation, when compared to rates of oxygenation, and when compared to ICU stay, when compared to any number of patient-oriented outcomes. But we do know that it's extremely better tolerated. Patients have something in their nose that's blowing air as opposed to a giant mask that prevents them from talking, prevents them from eating. They're getting air that's put to their nose to increase their fraction of inspired oxygen, and what they're not getting is high rates of pressure. And when we think about high rates of pressure into diseased lungs, it's no secret to anybody here that a low pressure strategy is what we've adopted in emergency medicine. So again, high flow nasal cannula brings us back to a rational approach to interventional mechanical support in patients with hypoxemic respiratory failure. High-flow nasal cannula is better tolerated in patients than more invasive and more aggressive non-invasive ventilation strategies. It leads to, at a minimum, better outcomes with respect to endotracheal intubation, with respect to patient outcomes, including mortality, with respect to patient outcomes, including ICU stays. It's cheaper when compared to non-invasive ventilation because it requires less respiratory support, requires less mechanical support, requires less logistic support. And in many places, many organizations and many hospitals, non-invasive ventilation requires higher escalation of care when compared to high-flow nasal cannula. High-flow nasal cannula needs to be a part of your practice for a number of reasons. High-flow nasal cannula is a return to a rational approach to an oxygenation-based approach in patients with hypoxemia without throwing in the additions of management of ventilation when it's not necessary. It's a return to a rational approach to oxygenation when you don't need to modulate Frank-Starling forces, because dabbling in things that don't need to be dabbled with is a lesson we've learned again and again and again, that it leads to worse outcomes. High-flow nasal cannula should be a routine part of your practice with hypoxemic respiratory failure. Ma'am? That's a really great question. We're going to talk about kids really briefly. High-flow nasal cannula, when we talk about kids, is, as all things, weight-based, right? We typically think of the question was, what about flow rates with kids versus adults? In kids, we'll jump into a little bit more. We think about weight-based flow rates. We think about 2 liters per kilogram as a common number. When we talk about adults, we standardize somewhere between 20 and 50 liters per minute most often. The sort of go-to, just like you throw somebody on the vent and you think of your 400, your 14, the sort of go-to that you'll want to start at is 40 liters per minute is where most people start off. At 100 FiO2 and 40 liters per minute is really the go-to, the standard, the rule of thumb in placing patients on high-flow nasal cannula. Extremely well tolerated, this humidified high-flow air, 100% fractions of inspired oxygen. Thank you. That's a great question. And that moves us so well, thank you, it's my plant in the audience here, to the question about what about in children? And what we see here is that it's fascinating. What we see is that it's difficult to draw conclusions because this went from a NICU population to an adult population and then was brought back into a PICU population, which is just a fantastic roller coaster of application of high-flow nasal cannula. But there are important lessons of this study from the Pediatric Critical Care Medicine in September of 2013. And this was a really great prospective observational trial that looked at using high-flow nasal cannula as the first form of respiratory support beyond standard oxygen therapy as compared to nasal CPAP. And again, what we get is the same lesson, that it's at a minimum just as good as CPAP, non-invasive ventilation, but better tolerated in this population. In the patients who got high-flow nasal cannula as compared to that big giant bubble CPAP on their nose, they required less sedation, they spent less time in the ICU, they spent less time requiring additional support. At a minimum, it's just as good. And I want to jump to a little bit of an abstract that's not here in your books. It's that lessons learned of high-flow nasal cannula in children. And many of you may have heard of this study, this abstract. This is called the Paris trial. So the Paris trial was published in 2018 in the New England Journal of Medicine, that old rag. And this looked at the addition of high-flow nasal cannula for patients with bronchiolitis. Anybody see patients with bronchiolitis every single day, nonstop? The addition of high-flow nasal cannula to children with bronchiolitis as compared to standard nasal oxygen therapy had fantastic results. This was that 2 liters per kilogram per minute lesson and that titration of high-flow nasal cannula in children that we just briefly discussed. And when these authors put children with bronchiolitis on high-flow nasal cannula at 2 liters per kilogram per minute, vice standard nasal oxygen therapy in bronchiolitis, they found a number needed to treat of 9 to prevent escalation of care, which is really tremendous and shows again that high-flow nasal cannula has a role to play in patients with hypoxemic respiratory failure. We're going to move to the next page here, and we're going to talk about apneic oxygenation during intubation. And this is, to some degree, talking still about high-flow nasal cannula. We're not talking about those fancy OptiFlows and Vapotherm. What we're talking about here is putting a nasal cannula in the nose and turning it up to the jet stream of air blowing down the nose when you're getting ready to intubate somebody, okay? And there are a number of ways we need to frame this before we jump into our abstract, all right? Before we jump into this, we need to set the clock back to 2001, when one of the the guru of emergency medicine, Rich Levitan, published a paper called No DSAT, Nasal Oxygenation During Efforts Securing a Tube. And what Rich Levitan taught us was that if you look at the anesthesia literature and if you look at some phase 3 trials, we find that if you put somebody with healthy lungs and you put them on a nasal cannula and you fire it up and you paralyze them, is that oxygen works really well, right? All of us did our ICU rotations when we did brain death tests and apnea tests, and oxygen goes down and follows a diffusion gradient and will go into lungs with less oxygen. And what we learned from the No DSAT trial is that putting patients on nasal cannula, a high-flow nasal cannula in the sense that you put the nasal cannula in and you keep turning that little knob to the left so it's blasting through the nose, that putting patients on nasal cannula during intubation perhaps potentially could lead to lower rates of desaturation during intubation, could lead to higher rates of the lowest SpO2. It could lead to better outcomes for intubation. And that drove this whole practice in emergency medicine. Wherever you went, that patients were put on these high-flow nasal cannulas and were put on nasal cannula during intubation, and it was gospel in emergency medicine. Everybody should be getting nasal oxygenation during intubation. But we need to frame this, and we need to frame this importantly, okay? Because when we jump into the abstracts here, we need to talk about the world that we're living in. How many of you, and there's no right answer here, and I'd be interested to know what the distribution is. You're going to RSI a patient, you're going to intubate a patient. You're getting ready, you give them whatever it is you do to induce and paralyze them. How many of you routinely bag those patients prior to intubation? About half, and that's probably about the distribution of what we see in these trials. Now, pure RSI in the emergency medicine world, for quite a long time, it's been advocated that those patients should not be bagged, that RSI is a bagless procedure. It's been hallowed lore in emergency medicine that bagging patients during RSI is, A, not necessary, and B, increases the rates of aspiration. And walk into any academic emergency medicine residency, and there's some zealot who's sitting there batting away BVMs from respiratory techs when people are getting ready to intubate. This isn't how we intubate in the emergency department. But we need to frame this in the right context, okay? Because when we look at Abstract 5 and when we look at Abstract 6, these were patients who were routinely bagged in the setting of rapid sequence intubation. So the question has to become, does this reflect my practice? Because maybe I don't routinely bag. But before we even get into those, we need to talk about a trial that was published just 4 days ago in the New England Journal of Medicine, the PREVENT trial, New England Journal of Medicine, Casey et al., which looked at routine bag valve mask ventilation in patients undergoing tracheal intubation in the ICU. But we can maybe extrapolate that a little bit to the emergency department. And what did they find? Not only did they find that bag valve mask ventilation led to better outcomes with respect to pulse ox, SpO2, not only did they find that it had lower rates of hypoxemia, they actually found lower rates of aspiration in patients who were being bagged versus not being bagged in patients who were undergoing RSI. Tremendous trial, which might be a game changer in emergency medicine. And we still have more to dissect from this trial. But right now, it tells us a number of things. If you're a zealot that bats away BVMs in emergency medicine RSI intubation, you might be wrong. You might be wrong. And so when we look at Abstract 5 and when we look at Abstract 6, where patients were routinely bagged during RSI, that might be more reflective of the world that we should be living in. And so Abstract 5 was a tremendous trial, the ENDAO trial, or ENDAO trial, which was published in 2017 in Academic Emergency Medicine. And what it looked at was the use of apneic oxygenation, these high-flow nasal cannulas, nasal oxygen turned up and blasting through the nose when residents were going to intubate patients with respiratory failure in the emergency department. And what did they find? They found that not only was there no difference whatsoever, they found that patients who underwent nasal oxygenation had no lower rates of hypoxemia, had no better apneic time, had no better outcomes than in patients who were not receiving nasal oxygenation. This was a little bit of a blow to the practice of everybody in the emergency department should be getting a nasal cannula before they get intubated. There were a lot of critiques in this trial. And they're not bad critiques. One, that these patients didn't desaturate because they were all too quickly, right? We're getting too good at intubation in the emergency department. The overwhelming majority of patients in this trial were intubated in less than a minute, right? They got their paralytics. The tube was in less than a minute. There was no time for them to desaturate. So that was a big critique and maybe not reflective of the people I care about, the possibility of them desaturating. If I'm going to be able to give you your sucks and put the tube in without a question, listen, you're going to be fine really no matter what happens. And that was a fairly significant critique of this trial. So then we move to the fellow trial. The fellow trial is abstract number 6, important, tremendous, and really game-changing trial here in emergency medicine, and a lot of lessons to pull out of this trial, just like Flurali, like we talked about earlier. The fellow trial was published in the American Journal of Respiratory and Critical Care Medicine and looked at ICU patients who were being intubated for respiratory failure. Really tremendous trial, and gave us a lot of the same information as the ENDAO trial, that patients who received apneic oxygenation during intubation had no better outcomes than patients who didn't receive apneic oxygenation during intubation. This shook the emergency medicine world a little bit. A little bit of the apneic oxygenation, the flag bearers were kind of taken aback from this because it seems with the combination of the ENDAO and the fellow trials that apneic oxygenation wasn't helping anyone. And these patients in the fellow trial, they were sick, right? These were ICU patients that were hypoxemic. They were being intubated by ICU fellows who aren't as good as us, let's be honest. No, I'm kidding. And they didn't have as good outcomes, right? They didn't have better outcomes. But there's a lot of stuff to look at, and we're going to sort of take a little bit of a right turn into the nerdiness, if you will, of statistics and the nerdiness of research for a little bit if you can. And the question we have to look at is, can we get the right answers if we're not asking the right questions? And that's a little bit of a loaded question. When we look at the fellow trial here, we can say, how did they examine benefit, right? So what was their primary outcome? A median lowest pulse ox, right? I want to put patients on apneic oxygenation and nasal cannula, and I want to intubate them. And my outcome is, if I take one patient and put them on the nasal cannula, and I take one patient and I don't, which one has the lower pulse ox? So the problem with that is you're looking at a continuous outcome, right? By its very nature, if that's the way you look at things, then a 93% is better than a 92%, and a 99% is better than a 98%, and a 50% is better than a 40%. Well, that's a little odd, right? That's a little bit odd because that's not genuine and that's not correct, right? It's not fair for me to say that a patient with a pulse ox of 50% is inherently just as good as a patient with is inherently better than a patient with 32% because they both suck, right? They're both bad, right? And if I begin to lump patients together and say, yeah, I got a bunch of patients that were 30% in the apneic oxygenation group, but in the non-apneic oxygenation group, they just did better. They were 33%. That's a little disingenuous. So a continuous outcome is a little bit disingenuous when you examine this here. By the same token, if I look at a dichotomous outcome, if I say, listen, if you're less than 80%, that's bad. If you're less than 70%, that's bad. If you're greater than 70%, that's good. We run into problems again, because here you're saying that, let's say that I was doing a trial and I looked at a dichotomous outcome of less than 90%, like this trial here. Well, that means that every patient that dipped below 90% was the same. That meant that the guy that I was intubating that hit 89% was lumped into the same group as the guy that went down to 20%. And that's not true, and that's not fair at all. And the reason I bring this up is I want to highlight how difficult it is to do these trials. So when these trials are negative, and when we report negative outcomes, I think it needs to be taken with a little bit of grain of salt, and it needs to be what I call not evidence-based medicine, it needs to be evidence-informed medicine. We all went to school, we all have letters behind our name, we all have any number of hours and years, decades of experience in the emergency department, and we need to take the lessons we have from our trials, and we need to synthesize them with our clinical experience and our values, right? My values are that I want less people with pulse oxes at 20%, and I want 89% if I can get it when I compare it to 20%. And that kind of value takes us to the next abstract here, the abstract number 7, which was a systematic review and meta-analysis. And just like Jim talked about earlier, what we can do with these systematic reviews and meta-analyses is we can synthesize more information and bring it together and maybe perform more complex, more advanced, and more mature manipulations of the data to pull out what we actually care about. Because again, what I care about might be different than what the authors of one study care about or what you care about. But all of this information can serve to inform my practice. And this abstract number 7 gives us a lot of really important information. That apneic oxygenation was associated with a significantly decreased incidence of desaturation and a higher lowest pulse ox. And that's the same lesson we get from abstract number 8 here, another systematic review and meta-analysis from the Annals of Emergency Medicine in 2017, which looks at apneic oxygenation in both adults and children and finds again that there was an increase in peri-intubation pulse ox, a decrease in hypoxemia, and an increase in first-pass success rate. So when I add this information together, when I analyze it in the way that I want to analyze it, it begins to mesh with my experience that, listen, for the most part, I'm going to get a tube in no problem, right? I don't want to say I'm the best intubator in the world, but all of you, the vast majority of your intubations are relatively uncomplicated, right? You give the sucks, you give the rocuronium, the tube goes in, no big deal. But every once in a while, it's a little bit of a thing, and every once in a while, there's a difference that needs to be made. And when I use a single RCT of a couple hundred patients, maybe that's not genuine. Maybe what I need to do is do larger systematic reviews and meta-analyses of many more patients to appreciate that the incidence of badness in intubation ain't that common, but the incidence of badness in intubation, when it happens, I want to know even the slightest benefit that I can get. So what is the takeaway of apneic oxygenation in patients with intubation? It doesn't hurt. It doesn't hurt. Probably doesn't do much for the overwhelming majority of patients, but it probably makes a big damn difference when it needs to make a difference. And we can move on to the next question, which is how good are we using low tidal volume ventilation for patients with Ards? Now, this is a difficult question, right? And there's a lot of interesting things to take away here. So Ards, the acute respiratory distress syndrome, which we may be familiar with, or maybe you trained after a time when consideration of ARDS was not part of routine practice. So ARDS was something that we've developed over the years and learned more about. We talk about the Berlin criteria. We talk about different PF ratios, that's PaO2 and FiO2 ratios, to define the severity of ARDS. But I think we should throw a little bit all out the window and take it back to Vietnam. Let's take it back even further. Let's take it back to Vietnam War and take it to Da Nang lung. Anybody ever hear Da Nang lung? These patients who get resuscitated or get injured and got lots of fluid during Vietnam War. And we learned that there's a fundamental difference between healthy lung and diseased lung. We learned that there's a fundamental difference in patients who are sick and their lungs are dying versus the patients who have endotracheal tubes for different reasons. They have endotracheal tubes because they can't protect their airway because they have a big head bleed. They have endotracheal tubes because they dabbled in any number of polypharmaceutical adventures and they can't protect their airway. These patients are fundamentally different. What we learned from all the ARDS trials, what we've learned from the observations of Da Nang lung, what we've learned is that there's a fundamental difference not between severe ARDS and moderate ARDS and mild ARDS and patients with pneumonia versus patients with PEs versus patients with granulomatous lung disease, that there's sick lungs and there's not sick lungs. And sick lungs benefit from low tidal volume ventilation. We can sort of put that stamp on it, right? Low tidal volume ventilation and low pressure ventilation is the right answer. It's the way to go in patients with diseased lungs. If I'm coming in and you're intubating me because I drank too much and I can't protect my airway, I don't think you need to listen too much about what I have to say because I'm a healthy guy and I'm going to do okay. But if I come in and my lungs are cheese or Swiss cheese and my lungs are dying and they're not doing well, maybe I have ARDS, maybe I just have unhealthy lungs, but the lessons are the same, and that is that low tidal volume ventilation leads to better outcomes for patients with diseased lungs. And what all of these next few abstracts tell us is that we do a bad job of making sure that happens. We do a bad job of low tidal volume ventilation. So let's talk really briefly about where this all came from. So the original ArdsNet trial, published many years ago, examined high tidal volume ventilation, which they called routine at the time, versus low tidal volume ventilation. And we can dive a little bit into that trial. What did that trial really look at? It didn't look at 500 cc's versus 300 cc's of tidal volume. What it looked at, again, was 12 cc's per kilogram of ideal body weight versus 6 to 8 cc's per kilogram of ideal body weight. Now listen, are many people here putting people on 12 cc's per kilogram ideal body weight of ventilator? I hope not, right? 1 liter is not a routine choice for me on the ventilator. I don't even know if it can go that high, to be honest with you. But the lessons still are the same, is that more volume in these patients doesn't help them do better and often helps them do worse. And when we look at Abstract 9, which looks at low tidal volume ventilation use in patients with ARDS, what they found was that patients don't seem to be being put on low tidal volume ventilation. That's much the same what we see in Abstract number 10, that patients in the emergency department with diseased lung aren't being put on low tidal volume ventilation. Now, Abstract number 10 I have some issues with. If you really take a close look at Abstract number 10, they take a look at patients and they say, listen, a couple days later, when we knew more and could give them more different diagnoses, and they had a progression of their disease, and we had a lot of information, and we retrospectively looked at what the emergency department did, how bad did they screw it up? I have some trouble with that it's not fair to retrospectively apply diagnoses and information to what was going on in the emergency department. But nonetheless, I think there are lessons to be learned, is that the way we put patients on ventilators in the emergency department needs to be rational, and it needs to be smart, and it needs to be simplified. And the way we should be doing it is dichotomizing patients into sick lungs and not sick lungs. And if you have a patient with a not sick lung, they should be on low tidal volume ventilation. What is that? That's 6 cc's per kilogram of ideal body weight. What's ideal body weight? It's height and sex, right? It's how tall are you, and are you a male or a female? You can throw it on ND Calc, you can get on the internet, you can figure out how tall they are, you can pull out your measuring tape, figure out how tall they are. But the lessons learned here are that girth, weight, is not what drives how big your lungs are. What drives how big your lungs are is how tall you are. There's a lot of people who talk about that a critical tool in the emergency department is a measuring tape, that every time you intubate a patient with diseased lung, you should be at the bedside measuring how tall they are, and you should be determining their ventilatory strategy based off of their ideal body weight. And that's another step in the way we work in the emergency department. It's a zero-sum game. Every time we add something in, every time we tell you to do another thing, we by our very nature are taking away from you doing something else, which is why I have a lot of problems with saying do more things, do this, add to your practice, because by its very definition, it means you're not doing other things that you could be doing, even if that other thing is going to the bathroom, right? Even if that other thing is just resting your brain for 30 seconds, which are important things to do. But what we know from these trials is that this is something that we probably should add to our practice, not because it's going to make the white coat wearers and the clipboard carriers happy, it's because it's going to decrease mortality in patients. It's going to lead to better outcomes for patients. And that's what we learned from all of these trials. And I'm going to take it one step further. If we look at Abstract number 11, where they instituted this quasi-experimental before and after trial, where they basically did simple teaching. They did this right here. They said, hey guys, do more low tidal volume ventilation in patients with diseased lungs. It worked. They had less people who developed acute lung injuries. They had less people who remained on the ventilator for several days. They had more patients that were placed on low tidal volume ventilation. And when we look at Abstract number 12 and they look at a systematic review and then they take individual patient data from all the trials, patients who were placed on low tidal volume ventilation from the emergency department right up front, they have better outcomes. They have lower incidence of subsequent ARDS, lower incidence of subsequent pneumonia. When we look at Abstract number 13, we get more of that same information, that patients who are placed on lower tidal volume ventilation have better outcomes. There's a place here where there's not a huge difference between patients who are placed on 7 cc's per kilogram versus 6 cc's per kilogram. There's probably not a huge difference between patients who are managed immediately off the bat with the exact perfect ideal body weight ventilation. But the lesson, I think, is important nonetheless, that we need to stop and move away from the routine, put them on 500, 16, 105, and walk walking away from the ventilator, and understand that what we do in the emergency department to manage mechanical ventilation in critically ill patients is not an additional thing that adds to our practice without adding to the benefit of the patient. It's something that we can add to our practice that leads to true end patient-oriented benefit. Decreased time in the ICU, which means I can admit more patients to the ICU. Decreased time on the ventilator, and decreased mortality. And it's something that we need to consider. Let's move to, I think, which is our last question here, which is how effective is prone positioning with patients for patients with ARDS? And I'm going to skip over abstract number 14 and move to abstract number 15 here, which is the PROCEVA trial, sort of a defining trial in mechanical ventilation in the ICU and the emergency department. What was the PROCEVA trial? It was prone positioning for patients with ARDS, and what the PROCEVA trial did was said, oh, listen, if I think way, way back to when I wasn't paying attention in medical school, I think about the west zones of the lung. And that's on the quiz when we finish, the west zones of the lung. There's no quiz. And what we look at is that if we can prone patients, and we put them on their belly, we have better outcomes for patients. Not just better outcomes in terms of less days on the vent, better outcomes in terms of it's easier to ventilate them, but significantly less patients died. And proning patients seems to come at a dose-dependent manner, that if I put a patient on their belly with ARDS and I ventilate them in that position for more than 12 hours a day and I do it correctly, these patients have better outcomes. And that's what the PROCEVA trial taught us. Now, abstract number 14 walks that back a little bit, is that mortality benefit seems to be most pronounced in the more severe patients, and it seems to be most pronounced in a dose-dependent fashion, that you need to do it for 12 hours a day. You need to not just put a patient on their belly and then lean them back, is that it seems to be, prone positioning seems to be a dose-dependent benefit in patients and really seems to shine most significantly in patients with more severe ARDS. Nonetheless, the lesson is clear, is that using the ARDS-net lessons in the emergency department can lead to better outcomes for patients. Using low tidal volume ventilation, knowing that patients benefit from proning, and we're not going to be proning patients in the emergency department so much, but knowing that the patients may be placed in prone positions, and so the way that lines and tubes and monitoring is placed on them can be beneficial. Or maybe you get called up to the ICU to manage a patient, and when you see them on their belly, don't be too surprised because it's better for patients. And then finally, our last question here is there a good review article that can help me direct ventilation in the emergency department? Of course there is, right? So the Titan of Emergency Medicine and Critical Care, Scott Weingart, Annals of Emergency Medicine 2016, really dives into managing ventilation in the emergency department. And I want to give a few summaries to managing ventilation in the emergency department. Managing the vent's complex. Managing BiPAP, CPAP, managing the vent, knowing the difference between oscillatory ventilation, knowing when you should be using volume control, pressure control, knowing how to move patients into different modes on BiPAP, and all these different things are incredibly important, and it's something that we're never going to get better at until we start spending the time on it. But it's something that's worth spending our time on. Management of the ventilator and good management of the ventilator is not something that's just a Gucci addition to our practice. What it is something that leads to better outcomes for patients overall. So the summaries that yes, sir. Absolutely. So what we're talking about here is not apneic oxygenation, but pre-oxygenation. It's such a really important point, we could talk about it briefly, is that pre-oxygenation is an incredibly important tool that we have in the emergency department, and washing out the nitrogenated area of the lungs and ensuring that as much of the lung is oxygenated as possible before intubation is really critically important. And some of that was that lesson we learned from Prevent in New England Journal of Medicine just 4 days ago, is that more oxygen in the lungs before you go manipulating around trying to shove tubes in leads to better outcomes for patients. And some of the original critiques of no DSAT were that a lot of those patients weren't adequately pre-oxygenated, that we were just diving in to shove tubes in them. But if you have the time and you have the ability, pre-oxygenation with high-flow nasal cannula or with CPAP or BiPAP really leads to better outcomes for patients. We talk a lot about flush rate oxygenation in patients for pre-oxygenation. That is putting them on that nasal cannula that you're going to be using for apneic oxygenation at 15 liters per minute, and then also putting them on the face mask oxygen at another 15 to 25 liters per minute, and just shoving oxygen down into their lungs to really adequately pre-oxygenate before you dive in with that endotracheal tube. So my takeaways, and just so we can move you on to break here, is that high-flow nasal cannula needs to be part of your practice. There's really no question whatsoever. Whether it's Optiflow, Vapotherm, or some other fancy tool, high-flow nasal cannula represents a return to a rational approach to hypoxemic respiratory failure in the emergency department. It leads to better outcomes for patients. There's very little question about that. Apnic oxygenation probably doesn't help most, but it might help a small component of patients. And then managing the vent, becoming familiar with the vent, taking a look at Dr. Weingart's article, and taking the time to spend to learning more ventilatory strategies is going to lead to better outcomes for your patients. That's all I have. Thanks, guys.